So coming back to our patient, looks like she has at least two high-risk prognostic markers, the 11q deletion and the IGVHM mutated status. Because of her cytopenia, she had a bone marrow biopsy done, and then it did show diffuse infiltration by CLL, confirming that her cytopenia is actually due to the underproduction from the CLL overinfiltration. So this is the case. In summary, a patient 66-year-old female presenting with pancytopenia, adenopathy, splenomegaly, has some high-risk features as we mentioned. So what do you think?
I think the first question that we should try to tackle as a group is whether or not this patient needs therapy in the first place. And what do you think? What are your criteria that you would use to decide whether or not we should intervene?
Mm-hmm. So I think the criteria for starting CLL treatment is pretty well established for many years. The IWCLL workshop has established the indications for CLL treatment. So basically, is indicated for a patient with CLL who has progressive cytopenia that's actually due to extensive involvement of CLL in the marrow rather than due to autoimmune process.
Do you think a Coombs and a haptoglobin is warranted here?
Yes, absolutely. Yeah, so actually before I would do the bone marrow biopsy, I would first do the basic anemia workup to rule out hemolytic anemia, rule out some other more common causes of anemia. And if that does not explain the patient's anemia, then bone marrow biopsy will be the next step. So bone marrow failure is one indication. The other indication is that if patient has progressive lymphadenopathy or hepatosplenomegaly, that's bulky or progressive that's causing symptoms. And then the third would be if patient has progressive B symptoms, although I would say typically those B symptoms are going along with the other indications as well. Yeah, and then another indication would be if a patient is having actually autoimmune hemolytic anemia or immune thrombocytopenia, but it's not responding to your typical immunosuppressive treatment. In that case, by treating the underlying CLL, that would be an indication as well.
I have a question for you. I just came from clinic before our tumor board, and one of the toughest things that I try to sort out are patients who have a constitutional symptom like fatigue in the absence of anemia, which actually is part of IWCLL criteria, is a constitutional symptom that could warrant an intervention. Any thoughts as to how to evaluate that or determine whether that's CLL related?
So I think that's a very important question, and it's one of the challenges as we all take care of our patients with CLL who may not meet some of the traditional criteria for treatment. The way I talk about it with my patients is that I think about many causes of fatigue, and I say that it's a big pie, and you have to figure out how much of a pie size is really because of CLL, how much is CLL contributing to that, because you have to rule out other causes, and unfortunately those are never really addressed in the clinic as an outpatient. So for example, hypothyroidism, depression, obstructive sleep apnea, these are all very under-recognized causes of fatigue. And what I tell my patients is that if you do not have a sufficient amount of disease bulk, generally significant lymphadenopathy or bone marrow infiltration by CLL, then it is less likely that the fatigue you're experiencing at the early stages of your CLL disease process is because of CLL. And then if it is not truly CLL that's causing the fatigue, by treating the CLL, your fatigue is not going to get better. And so we would not have done you any favors by treating your disease. So we would ideally like to investigate additional reasons for fatigue before proceeding with treatment for CLL.
I guess you've all encountered the same situation before.